I'm Rebecca Pierce with Lower Cape Fear Hospice and Life Care Center. And our group talked about coming to grips with end of life, and we were kind of tasked with looking at ways to get people to look at end of life to minimize cost factors, to maximize quality of life, and those sorts of things. And so in the background, we said, that part of what we're doing is trying to plan for how people want to live out their lives. We don't want to talk about how people want to die necessarily as to how they want to live their life. And that there's a need to broaden the model of end of life in general. End of life is not the last 5 days, it's not the last 2 weeks, sometimes it's 5 years. And we want to get people to be aware that end of life is bigger than just your last 2 days in the hospital. Culturally, what did we say? That culturally, obviously, if it's un-American to die, you cannot be an American and you cannot die. You can't die as an American. So that planning for end of life is taboo and uncomfortable. We don't even want to talk about the word death. That we are not clear on how and when the conversation should start. That there's obviously confusion amongst the community. That I'm not even sure if my 65-year-old mother has got her advance directives filled out or had those conversations. So finally, we said that community programs aren't connected. That again, the U.S. culture doesn't expect to die, that there's lots of avenues and options and resources for people to discuss end of life, but sometimes we're not all connected on our messaging. So currently, we said that we talked about end of life being palliative care and hospice, which we all know it's bigger than just that, but that was one of the pieces of end of life. So we said that structure actually works as far as what it does for a patient, but the problem with that is that people don't even understand what palliative care and hospice is. So that was part of the problem, that there are many current programs in our own region. So we listed a bunch of the programs that we currently have in place that we could work with. We said that patients have their own expectations from the process, and that makes it a little bit more difficult individually, one-on-one, having those conversations because everybody's expectations are different. We think that there needs to be more collaboration across disciplines, partnerships, communities, organizations, and that there is a uniqueness in the disease or person that makes it difficult, which I just said, about how to have these conversations. So finally, we came to our proposal process, and we want to first off identify some best practices. We talked about what exactly about end of life is it that we're trying to focus on. And we came down to down the little path of looking at advanced directives, because we think if we can get people to start talking about end of life and they start planning for what their end of life is going to look like, then we can make an impact on how their end of life actually happens. So we want to identify some best practices. We thought about, like the La Crosse, Wisconsin that everybody knows about, and some other programs across the country. So we're going to do a little bit of research. And we're going to look at more collaboration. We've identified some organizations, agencies, things within the area that we're going to start identifying as partners, and finding ways for us to get them involved so that we can start talking about advanced directives. For instance, there are the junior leagues, there's the churches, there are, we said, for instance, UNCW. We think this is more than just a discussion for people at 65 and older. We think these are discussions that, well, I can't personally define the age, but even at 18, you need to recognize some mortality. Even maybe 18-year-old boys don't, but you want to at some point start talking that we will die, and that so we want to get all the people. We want to get various people on board from different parts of our community. And one of the big barriers to this, though, is we were talking about we can all fill out advanced directives, but what happens if something happens to me and I'm rushed to the hospital and my person that's supposed to have my advanced directives doesn't have them? How do we get access to that, and how do we actually impact the end of life experiences if you don't have advanced directives readily available? So one of the things we really want to work on is the storage of advanced directives. So we tossed around ideas of how do we get some sort of database that people can access, not just healthcare providers, but also family members, myself, so that I can update my own advanced directives. So we're going to identify some options for storage for advanced directives for our whole community. We want to start the conversations earlier. Like I said, somehow outreach to local universities, colleges, find organizations that have younger people in them. and start having those conversations. Not only are those people making the decisions for themselves, they're making the decisions for their soon-to-be parents probably who didn't fill out their advance directives and things. So all the more reason to identify younger and earlier people. And then train the lay people. We said we want to start training the lay health people in end-of-life conversations. So we can't physically reach all 200 and some thousand people in New Hanover County, not to mention all of the surrounding counties. So one of the ways that we can have an impact is to do the train-the-trainer approach. And so we thought about going out and finding some people within certain organizations to be kind of our champions and train them on how to train other people to start these conversations. And some key points that we said was, you know, if we're going to ask providers to be involved in this and start helping us have some of these conversations, then we want to make sure that those providers, as well as train-the-trainer type people, have done their own advanced directives. It's kind of surprising how many people are out there trying to have these conversations, and it's hard for them because they haven't even done it themselves. And that we want to dispel the myth that the conversation only needs to happen once, that this is a conversation that needs to be brought up annually on a regular basis, and that it needs to be updated. And so it shouldn't just be something that you have once, then you walk away, and 20 years later you've never even gone back and revisited, because obviously your situation has probably changed in 20 years. One thing that I didn't write down, we didn't write down on this, but the exciting thing is that we have lots of things already happening in our community. And so we started identifying those, as I said. And one of the big tools that we want to utilize is something that Lower Cape Fear Hospice's organization has developed, which is a begintheconversation.org. Some of you may have heard of it. And it's a statewide program, and that we want to incorporate even more on a local, regional basis. And so there's a tool for us to utilize. Now we just want to take that tool and utilize it in these forms and fashions so that we can actually get it out into the hands of people so that they can start looking at advanced directives and having those conversations. We left open some unresolved issues, things that we want to revisit sometime in the future, including some education on grief education. That also coming to grips with end of life is about how to deliver difficult news. So there's a provider aspect there that we haven't yet touched on. And that there's, we want to explore some cultural partnerships, because the same way as CHEC is having us talk to our peers today, it's the same thing as having someone from different cultural and socioeconomic backgrounds and things to also work with similar groups so that they can talk about these sorts of issues in the way that someone else would understand. So we are planning on doing a little bit of work, like I said, research. We're going to do a benchmarking survey. Don't be surprised if you see a survey monkey, please respond to it, on how to, on whether or not people have completed their directives, and get some background information. And then we're going to start implementing some of these action plans and continue to resurvey and see what kind of a difference we're making in that. And we did note that in April, close to that April 6th date, that there's a healthcare decision day that we're going to maybe plan some stuff around and do some community-wide events there. I think I hit it all, hopefully.
Awesome. Great work.